All right, and welcome back from your break. I hope everyone had a great time in the breakout session and started to get a better sense of what is needed for more effective program planning. So, thank you so much for your participation. For our second morning session, we will have two presentations. First, we will have Anthony Green, Structural Intervention Coordinator in the Center for HIV Prevention and Health Services, facilitate a community panel on how we strengthen our outreach approaches for reaching individuals that identify as Black and same-gender loving, transgender, and gender nonconforming. Following the Q&A for that will be a presentation from Dana Wachter, Division Chief of Program Development in the Center for HIV Prevention and Health Services, who will talk about service standards for HIV prevention testing and early intervention services. Thank you so much, and we'll turn the floor over to Anthony.
All right, thank you so much, Aaron. Like you said, I'm Anthony Green, and I'd like to welcome you to Outreach Strategies for Black, SGL, Transgender, and Gender Nonconforming Persons. I will be your moderator for this panel, your Andy Cohen, your Oprah Gail Winfrey. I am all of those things. So without further ado, I'll let our esteemed panel introduce themselves. Please keep your responses brief, because remember, this is not a TED Talk. Esteemed panel, please tell the people who you are and what made you agree to be a part of this discussion. Let's start with Joseph.
Okay, good morning, everyone. I am so honored to be here. I am so very thankful for the invitation. My name is Joseph Reaves. My pronouns are they, them. I am a resident of Washington, D.C., Ward 5, by the way of New York. Have been here in the district since 2008, was brought here by Howard University, like a lot of people. And I am a community member who loves being a part of transformative conversations. And I am just seeing this as a conversation with friends that you all will be privy to, because I see a lot of my folks, a lot of my good Judies on the line today. So we're going to keep it professional, but it's going to be a professional keep. And I think we need to have a little bit more of that in these type of spaces, which is why I chose to be a part of this, because I do think that we need to find ways to combine the clinical and the professional with the communal. And for me, I think that also means making entryways for the populations that we serve to actually be employed in this work and to actually be able to make a living in this work, because HIV is not just medical, HIV is not just sexual, but HIV is also about socioeconomic determinants. And we know that so many times those that are most vulnerable are vulnerable because of their socioeconomic status. So making ways for Black queer folks to actually be able to survive and thrive without 50-11 credentials and letters behind their name is also incredibly important, and just why I wanted to be here.
All right, well, thank you so much, Joseph. I always count on you to wake the girls up. They woke. All right, let's move on to Ian.
How you doing, everyone? My name is Ian James. My pronouns are he, him. I come from HIV and pediatrics background, so I've typically worked with patients who are HIV positive between the ages of 12 to 26. I've recently moved into Chase Brexton, for which I am all ages now. So I have about 8 years experience with dealing with the Black community, in HIV specifically, the LGBT community. And I joined this panel discussion because I think it's important to have representation and to see people working on multiple different fronts and being able to understand what it takes, specifically within the Black community, to be able to distribute information, whether it's preventative or otherwise, being able to do that and being able to have an outlet for everyone to be able to understand who's who and where to go to.
All right, thank you so much, Ian. Let's move on to Rhonda. Rhonda, tell everybody who you are.
Good morning, everyone. I'm Rhonda Carr. I am a community outreach worker for Jocks Initiative. I've been in this work since 2012. The reason why I am on this panel because I want to be a representation of all the ladies out there. I don't see any, I'm the only woman on this panel, so I'm here to represent the women, trans or cisgender, whomever. I represent them all. I'm here just to be a voice of reasoning for the women who look like myself and identify as a female. Hello, everyone. Good morning.
Thank you so much for being here, Rhonda. I'm looking forward to talking to you. Let's go to the next caller on the line, Malachi.
Good morning, everybody. So I am here. My pronoun preferences are he, him, his. Currently a DC resident, a Philadelphia native, so Big Philly is in the building. I currently work as a public health analyst at DC Health, as well as the testing coordinator. And I'm here because I think this is a conversation that we don't have enough about a population that doesn't always get enough attention. And certainly not when the conversation is had, it's not always from the people who reflect the community. So I'm honored to be here with my peers and to have a conversation with people who are actually the subject matter experts. So good morning, everyone.
All right, very good. Let's move on to Mr. Monte. Oh, don't forget to unmute, Monte.
Sorry about that. Good morning, everybody. My name is Monte J. Wolfe. Thank you for inviting me to be a part of this. I am an actor, writer, producer. I'm the founder of Brave Soul Collective, which is an arts education and outreach organization with a focus on HIV and issues affecting the Black LGBT community. I also have been writing for WebMD and their blogs for the last year as a person living with HIV. And I've been living with HIV for 17 years and counting. And I feel this work is important because the bridge between arts and activism is one that's very real. And it's something that is always very useful in reaching people and making sure that people are seen and making sure that, as Joseph said, those people who are underrepresented and undervalued have a voice. So in large, I said yes because I love Anthony and he's my brother in the arts and the creatives, but I also have worked for Us Helping Us and have been doing this work in prevention. And like I said, towing that line between creativity and arts and prevention for the last 15 years. So I just felt it was important to try to be a part of this. So thank you.
Thank you so much for being here, Monte. It touched my heart that you even made time for us today. I know you're a very, very busy man. All right, so last but not least, one of my favorite people on the planet, Jammine.
Hi, good morning. My name is Jammine. I am an advocate and activist for left politic in the DMV area for Black and gender non-conforming people. I myself am gender non-conforming. I identify as non-binary. Pronouns are they, them. I'm very excited to be here. I chose to be here because I feel like there's a perspective that is very unique to non-binary gender non-conforming people that I hope to bring. And I also hope to bring a degree of empathy to this discussion and how we talk about HIV prevention. Thank you.
All right, very good. All right, so I think that is all of our panelists. Let's give them a virtual round of applause. Okay, so with all of these identities, same gender loving, transgender, gender non-conforming, each of these perspectives could be their own panel, even their own conference. So, but we're gonna try to give you the Cliff Notes version of all of these perspectives in the small amount of time we have. So let's go ahead and jump right into these questions. The first one that I have is, so what are the current challenges in serving this population for outreach? This could be specifically as a whole for all three, same gender loving, trans, or gender non-conforming, or panelists can answer just specifically about the population that they're representing. Let's go ahead and start us off with Joseph.
Okay. The immediate challenge that I see in my day-to-day life as a Black queer person post-COVID, while we're still very much moving through COVID, is lack of accessibility. Outside has opened back up for better or for worse, but I still need to set an appointment for an HIV test. Like that's a problem, because I know, and then, you know, like Monte, I also spent time working at Us Helping Us. And really, one of the great things about pre-COVID that I think it is long overdue to bring back is, if I just knew at the spur of the moment I had some free time, I could just walk to Whitman Walker. I could just walk to Us Helping Us. I could just walk to this, that, or the third place and just get walk-in testing so that I'm keeping some regular regimen, to where now there is just this very visible reticence for providers to go back to walk-in testing. To where I've called into places and have had people blatantly tell me, "Oh, I hope we never go back to walk-in. I hope we keep an appointment." Meanwhile, once again, outside is back open, so your vulnerable populations are out there having sex in the midst of COVID, in the midst of monkeypox. So I think it's, you know, and it's surprising to have to say this, considering all the great work that we were doing and all the great infrastructures we had in place pre-COVID, to have to come back to this point to where now accessibility is back to being an issue. I also think something that we need to work on is like tokenization. And this goes back to some of my original comments about making sure that people can make a living. We love for folks to come in for a study. We love for folks to come in for an incentive, but we ain't getting nobody no jobs. And it's kind of like, I mean, I was listening to a podcast from someone else that worked in public health, and it's like, you go in for the interview in the suit and tie, and they tell you that you're too clean and you're too professional and that the populations won't be able to relate to you. But if you come in looking like the population, they say you're not professional enough. So it's like, so it's like this catch-22 where you can't win for trying.
Thank you so much for that, Joseph. You just delivered a word on this morning, and I don't think everybody ready. Any other panelists want to jump in on this question about specific challenges for the population? For like random, all right, I'll go to Monte.
I echo everything that Joseph said. And like he said, as people who have worked in prevention at places like Us Helping Us, where there were testing events, where there were, you know, things that happen at clubs like the Mill, or where they set up, you know, mobile vans and all those other kinds of things. I think access is the most important piece of this. And there's oftentimes a disconnect between the people that are doing this work and the people that they claim they're supposed to be serving. And if that can't be rectified, or those things, you know, it's fraught. And if those things can't connect so that there's a spark of electricity there, the people that you're supposed to be serving don't trust you. They don't feel like you see them, or like, you know, like they're represented. And then what we get from the other side of the people is, okay, well, how do we reach this population? Or, you know, how do we do this? And again, I think a lot of what Joseph said is very true. So a lot of the stuff that I've been challenged and called to do, focusing on the arts and allowing us to be able to put things together where there are real life scenarios and things that, you know, are not pie in the sky things, but real life things where we, you know, tell the truth, even if it's not pretty, and even if it, you know, makes somebody uncomfortable. Because if your focus is to serve the population, it's not about trying to appease your ego and make you feel better about being in this position. It's about what are you doing to reach the population that you're being paid to serve. So I think that a lot of times access and just being able to hear and pay attention to the people that you claim you're supposed to be serving is imperative.
Period. Thank you, Monte. This person doesn't have their hand up, but I feel like Malachi has something in his spirit that he wants to contribute to this question.
I just want to echo everything that is being said. And I kind of wanted to give an anecdotal example so people can see what that really looks like. just how the respectability politics often keeps us either out of the conversation or puts us at the bottom. So we have the people gatekeeping who don't look like the community. And when I hear people talking about access, right, I think about how one of the programs I just took over was Get Check DC. So for the last 2 years, people don't even know that they could get HIV, STI testing mailed to their home, condoms mailed, because the person who was running the program before me does not reflect the communities. So when I went over to east of the river and I'm going to these populations, these CBOs that I know are doing the work, and they're asking like, how long has this program been? I want to say just in the last 2 months, like we've seen the amount of requests like quadruple, just because we're finally reaching the population. But when we're left out the conversation, when we're left out of, the room where these decisions are being made, the target populations don't get reached, because when you hire people who fit into the respectability politics and not the people who fit into the community, you actually lose a lot of opportunity.
Yeah. Thank you so much. Y'all are doing a thing. Like, I picked the right people for this panel because y'all are saying the truth. All right. So how has the nature of outreach evolved? Oh, can you hear me? All right, so how has the nature of outreach evolved in the age of social media since the COVID-19 pandemic? All right, let me see anybody wants to jump on this question?
I can jump if it's okay.
No, let me get Ian, can you jump in on this question?
Sure, you asked about how social media has changed since COVID involving.
Yes, has the nature of outreach evolved in the age of social media since COVID-19?
I think for social media, it's been a big impact for outreach. Considering that before we were going out in the streets, we were doing a lot of, well, for me, I'll speak for me, I don't know about everybody else, but as far as my outreach was concerned, I was going out in the streets, different hours, unconventional work hours, typically maybe midnight to 2, things like that. Doing a lot of the footwork that it requires to get out in the community and be able to reach people and be able to have people understand that you're coming to them humbly, and you're not just trying to get some type of name written down, or you're not trying to just do what is required of you. It means something to you. And so now, since COVID, social media has allowed us to be able to get in connection with those that might have not been out there. Because sometimes when you go out, you don't reach everybody, even when you do go out physically. So social media allowed for me to be able to reach people that may not have been out in the street, that may be home, that may have a different lifestyle, to be able to get them to be able to understand their needs and to be able to fulfill that as well. So through that, I've been able to do condom distributions. I've been able to get people to come in and get tested. I've been able to do a little bit more than I could have physically. So it turned out to be, even though social media is like a double-edged sword, it turned out to be something really beneficial when it came to outreach for me.
All right, thank you, Ian. Thank you for getting that condom distribution, keeping that going, because I personally appreciate that. Rhonda, can we go to you for this question? You got a little something? I want to feel your spirit a little bit.
Yes. So how has social media changed? Well, basically, we have done a at-home testing kit where we sit on social media, we have different conversations. We have a condom distribution program as well, with all types of condoms, magnums, lubrication, water-based, silicone-based, which is kind of easier to do when you're dealing with on social media. It's easy to like hit you up in your inbox and say, hey, I need some condoms, or hey, I need a test. So that's how social media has changed outreach after the pandemic for me. The way that I have to be more creative. My biggest thing is my personality. I bring a lot of people to the yard. I'm a very loving type of person. People trust me in the community. So that was easy for me. Pre-COVID. Post-COVID, I have to be a little bit more creative, have to get some type of things to bring them to my my social media postings or me having lives and talking to them. So I just have to be more creative. So just you have to use your creative juices is what I've learned in this time and age.
Well, thank you so much for bringing the folks to the yard. All right. Joseph, do you still have something you want to add on this question?
I lost my thought, so you can come back to me next time.
No problem. So we'll move on swiftly and professionally to the next question. So how do you balance being a part of the community while serving the community at the same time? Anybody feel passionate about this one? Rhonda, all right, go ahead.
Okay, so how I balance it is that I am big in, I'm in ballroom. I'm also in the Marching Band community, which is another different community in Baltimore City that I deal with. So the blessing is in it is that people know that I'm a person that can tell their deepest, darkest secrets. It will never leave my soul. It will never leave my mouth. I've never been that type of person who's put anybody's business out there. I've never been known for that. So that is a blessing that I have, that people can come to me knowing that I work in this field. I've done commercials. I've done different things. I've been on poster boards all over Baltimore, Maryland. And people have been asking, are you this? Are you that? Honey, I'm just here to spread the word about being safe and being, if you're positive, that you can be undetectable. So I'm just here to spread the word. So for me, it's a blessing and a curse, because sometimes when I'm out there trying to party and live my best life when I'm off of work, some people always come back to me like, hey, I have a question for you. So when they have that question, it's like, okay, so now I have to get out of party mode and go into professional mode. So it's like a darned if you do, darned if you don't kind of thing for me. So it's a blessing, because I know that people can actually come to me and actually feel safe, and I'm one of those people they can come to. So it's kind of good for me. And then it's also like when I'm really trying to turn up or have my good time, I still have to deal with that as well. So it's a balance that I have to maintain, but I've done well with it, and I've been successful so far. So I'm just going to keep being me and living my life the way I have. So that's what I have.
Thank you so much. I appreciate that. Monte, thank you. Because I was going to come to you anyway, Monte. So you're reading my mind. All right, go ahead.
I'm sorry. That just spoke right before me. I want to make sure I'm calling her name.
Rhonda.
Rhonda, thank you. Because what's on the Zoom is just initials. So as Rhonda said, I think it's just about being like shown, like keep trying. Like I think we just have to keep trying. I think it's a tightrope that we walk in doing this work. Sometimes I don't really think there's a place where one begins and one ends. It's all like one continuum. It's like you show up, you allow yourself to be visible, you tell the truth about who you are, and in that, you enable other people to do that. I mean, a part of what it is that I did with starting Brave Soul Collective in 2006, which was basically about a year and a half after I tested positive at age 30, 3 weeks after my 30th birthday, when I found out that I was HIV positive. About a year and a half later, I was called in a spiritual gathering to start this organization, because I felt like we needed visibility as Black gay men who were living with HIV, and also the other side of that, me being an artist and feeling like, I worked in these communities, and I felt like there was a way to be able to tell my stories and the story of so many other Black gay men, trans people, non-binary people who didn't have a voice. So I think that for me, it has not always been easy. A lot of times, as Joseph said, and for all of us who work in prevention and outreach and all these other kinds of things, a lot of time those calls are coming from inside the house. And what I mean by that is we get overworked. We don't get appreciated. People will, try to blow smoke up your behind and tell you that they appreciate you while continuing to overwork you. And I think that a lot of that, what I've had to learn over the last 15 or 16 years, is sometimes you have to, sometimes you have to teach people how to treat you, even in work settings and all these other kinds of things, in terms of expectations, in terms of what is being asked of you, and in terms of how that's coming out for you in terms of benefits or all those other kinds of things. Just lastly, very quickly, I think the other piece of it is, and I've learned this even more since COVID has hit and changed the landscape of everything. It's about us being able to take care of ourselves and, making sure that a lot of times boundaries and being able to, again, even in these professional settings or in artistic settings or whatever, being able to say no. and being able to say that no is a complete sentence, because I can't overwork and burn myself out. I can't give to the community if I don't have anything else to give. And a lot of times I think that as artists, a lot of times, people try to play in our face, because it's like, they want what we got, but they don't want to compensate for it. But they'll go get a Real Housewife of who gives a damn to show up at an event and be, and floss and do this, that, and the third. And that's fine. But those people don't speak to the community. They don't have the ties that we have. So again, I think we have to have that balance in terms of doing these things and making sure that we appreciate people, because if you keep mistreating people and you don't value them, they're going to go somewhere else. And ultimately, you have to be able to take care of yourself. So for me, it's been about striking a balance. It's been about telling the truth. And just the proof has been in the pudding for me in terms of when I do this work and when I'm telling the truth, letting other people letting me know that what I've done and what I'm continuing to do is helping them. That's what continues to fuel and feed me.
Thank you, Monte. You better be out there telling my story, telling my business, killing me softly. I appreciate that. So we have a really cool question in the chat, but first I want to ask a specific question so that we can get Jammine in the room. Jammine ain't saying nothing yet. All right, so my question is, and we'll start with Jammine. So in your perspective, as the youngest person on the panel, what are the views of this generation's young people on HIV?
I think that's a good question. I think that right now, in my experience, in my opinion, and statistically, I think a lot of young people do not take HIV prevention as seriously as we probably should. I think, unfortunately, a lot of younger people see HIV as a issue for the past, and in a lot of ways, a manageable issue to have at all. Right. I think that there's a lack of acknowledgement from a lot of people that HIV is still stigmatized, that if you do not have the proper health care, your HIV is not manageable. I think another issue is that for a lot of young people, a lot of us go to get tested when it's needed, not routinely. I have friends, loved ones who only go when there are instances where a partner, a sexual partner, tells them, hey, I am experiencing these symptoms. You should probably go get tested yourself. And that's just because for a lot of us, HIV feels like an issue for, if I'm being honest, for a lot of people, younger people, HIV feels like an issue for our elders and not for us. And I think that to carry a legacy of respect, a legacy of dignity, we can't think that way. We can't feel that way, because in a lot of ways, that's devaluing the people that came before us and the people that are here now experiencing a lot of those issues. Because for a lot of people, when the issue is not yours, you don't have to advocate for it. And you don't have to stand up for people who are stigmatized by that. And you don't have to find yourself in community with people like that. And I also think there's another issue. I'm sorry to be going on so long, but I also think there's another issue of why younger people are not connecting with that issue, is because in order to connect with that, you have to be in community with those people, with people who have loved ones who are HIV positive, who are themselves HIV positive. And unfortunately, with certain stigmas, class stigmas around it, when it comes to desirability politics, respectability politics, like we were talking about earlier, people do not want to align themselves with people who are not seen as desirable, people who are stigmatized, people who may or may not be poor, and things like that.
Thank you so much, man. I'm so glad you are here on this panel. Working in this field, I hear a lot of people talking about, the youth being a specific population that we're targeting, but I'm rarely in spaces where we hear directly from the youth versus somebody telling me what the youth say, think, do, or feel. So I'm so glad you're here. So I have a specific person I want to go to, but does anybody else want to specifically hit on this question, or can I go to my person? All right, so Ian, will you add a little more to this one for me?
Sure. Could you repeat the question one more time?
Sure, Ian. Okay. So the question is, in your perspective, what are the views of this generation's young people on HIV?
I think it's relatively positive. Considering that that's primarily my background, dealing with youth and HIV. Just based on my experience, they handle it a lot differently than the older populations do. And so a lot of them understand that the immediate care is the best way to get undetectable, the best way to prevent any further infections, any further situations that may occur. And again, just from my experience, it's not so much of a taboo. I think a lot of the times when you have community within the youth, especially with programming and things and being able to bring them together, a lot of times the conversations that I had between them create an even better environment for them to be comfortable to either be comfortable with their status or be comfortable with someone that has a status, whether it is positive or undetectable. And so I haven't had any negative responses with youth. A lot of the negativity and a lot of the struggle comes from persons who may be older or may have contracted HIV later in life. And so even with that, it's not always perfect, but with the youth, definitely, they handle it a lot better. And so I don't really have any negative thoughts or any negative feedback as far as dealing with the youth and HIV.
All right, thank you, Ian. Well, let me jump to the question in the chat. All right, the question is, so what is the best way for programs to find people who do the work who actually reflect their community and let them know when we have these outreach job opportunities available? So where can we advertise these job opportunities so that we can actually find the proper people who do the work? Can we jump to Malachi? I haven't heard you in a minute.
Sure. So to be honest, my perspective on this is that it's less about like not advertising in the right place and more about not advertising with equity, because we often want to pay us, like the bottom of the scale. I watch how the advertisements work, and I've seen people who come with expertise who move really the weight of a program, and they're trying to get the most from us, from people who reflect the community, for as little as possible. However, if you bring somebody in who doesn't reflect the community, they must be an expert, they must know a lot. So we have to pay them top dollar when really they may know a lot about how things work in theory, but very little about how things actually look in the community.
Very good, very good. All right, Joseph, do you have something you want to add?
Yeah, because I almost felt like my initial comments brought up that question. So I wanted to be responsible and try to offer a solution. But I'm going to piggyback on what Malachi said. It's not about knowing where to go, because you can know where to go, but if you're expecting people to have 15 years of experience and three master's degrees, so it's not that we don't know. We know, but you don't let us in the door. Okay. And going back to Malachi's experience, I mean, I was a part of a program where let's just go on and say it. I was a part of a program where on its face, it looked like I had a lot of prestige and privilege. I mean, I was able to work for DC government and in DC government, right? But I was being paid minimum wage and wasn't allowed to work 40 hours a week, because if you work 40 hours a week, then you were eligible for benefits. So they'll let you work 39.5, but you better not do that extra half an hour, because we're not going to pay you. And once you do that extra half an hour, now you're a full-time employee that's eligible for benefits.
Yeah. All right, thank you so much, Joseph. Nobody piggybacks like Joseph, baby. Nobody piggybacks. Hold on, Joseph. We gotta move on to Monte because we ran out of time. But let me jump on Monte. Oh, unmute.
Sorry about that. Just very quickly, I think everything that Joseph and Malachi said, I'm going to echo those things because, and I think as Joseph was just speaking, I think this is very characteristic of what we are hearing all this stuff in the news about. And I love how they try to put these names on these things instead of just calling it what it is, quiet quitting and all these other kinds of things. I think that all of what we're talking about extends to every other profession because, again, I work in performing arts and arts organizations, and we deal with the same stuff in terms of them expecting you to have this, that, and the third in terms of degrees and all this other kind of stuff, as opposed to the on-the-ground experience in terms of being able to know how to serve the audience or how to serve the people who are your target audience. So I think with bringing it back to this, if you really want to know, like they said, it's less about how you reach those people, but what you do when you get them there. I think that a lot of these systems are set up, they're still dealing with these old antiquated ways of hiring and expectations. And I've had to do these things in terms of hiring people and interviewing or what have you. And I think that, you can't throw all of that out the window, but I think the more you're willing to bend on that and lean more into who is this person? What do they know? What have they done? And paying attention to those kinds of things, and then putting that money where the mouth is in terms of what it is that you say you want to do. Because again, if you don't appreciate people and if you don't compensate them adequately, then what are we doing? That's the thing, because as much as we have a passion about doing this work, we are people, we need to be compensated and we need to be appreciated and not just, played with.
Thank y'all so much. Thank you. All right. So one thing I'm really happy about is on this panel is that we have gender non-conforming people like representing and present. So this next question I'd like to ask, so what should be done to bring more gender non-conforming people to the table in planning and implementing HIV-related strategies? And I'm going to start with Jammine on this one, and then Joseph, be getting ready.
I think that's a great question. I think a lot of the times when it comes to how events and how different things are marketed, I think a lot of the time they are marketed specifically to cis gay men and also certain type of cis gay men, right? I think a lot of the time you see people who have a certain look to them when it comes to they're not older, they have certain body types. I think that there is a lack of acknowledgement of like disabled people. And I also think that when it comes to gender non-conforming people, a lot of the time we are just not acknowledged. And I think when it comes to marketing events, when it comes to in creating inclusive spaces, there has to be a lot of acknowledgement, not just a little bit, but a lot of acknowledgement that queer people, gender non-conforming, non-binary people, not only do we exist, we are like pillars of the community that we're a part of, and that we deserve to be catered to as much as anybody else. And that we shouldn't be forgotten about, or we're not an asterisk, right? It's not he, she, and then, oh, my bad, I forgot about the days, and I feel like a lot of time we do get forgotten about, or we are put into different pigeonholes, right? There have been a lot of spaces where as a gender non-conforming, non-binary person, people just decide that I'm a man regardless of what I say, right? People put me in the man category, whether I identify with that or not, in a lot of spaces, right? Filling out forms. I know this is like really simple stuff, but like filling out forms and then like there's just not being an option where I don't get to say if I'm a man or not. I would love to see more gender non-conforming people hired in a lot of these spaces. That representation is very important because that empathy is very important. That experience is very important. They bring a different perspective that is extremely important, and that needs to be acknowledged because you're catering to us. I would love to see us paid and compensated and catering to us.
Thank you so much. Y'all keep talking about compensation, pay. I'm going to have to cash app y'all after this. All right, so Joseph, I need you to go ahead and piggyback on that for us.
And like the compensation is real, right? And I mean, we kind of laugh it off to like help it land a little bit soft. But as someone who make, and it can be argued that I make decent money, but I still can't afford a studio apartment where in the district in which I live, working 40 hours a week at a salaried position. But I don't want to focus too much on that in this space because I know we have limited time, and I want to make sure that I answer the question that you directed to me. To make the space more welcoming for gender non-conforming people and non-binary people like myself, realize that as non-binary folks, we don't owe you androgyny. And to present as androgynous, or for me to come in this body that is designated as male and to put on heels or to wear a dress is actually a safety issue. So as much as I may want to, you have to factor in the fact that I want to make it back to the same safe, warm, and comfortable bed that I got out of this morning at the end of my day. Okay? So gender non-conforming and non-binary folks do not owe you androgyny. And then also, and this goes back to Malachi's point around respectability politics, when gender non-conforming folks and non-binary folks do choose to embrace androgyny, make space for them and don't block them and don't cause harm to them under the realm of quote unquote professionalism and quote unquote professional dress. Because even before I started to embrace my truth as a non-binary person and as a person who is neither or, but also both and. It was a Black gay man that was the head of a Black gay organization that sat in a meeting and said, if I go to a doctor and they're in a t-shirt and shorts, I'm not going to trust them to take good care of me. And for me, I could care less what you have on. I want to know if you can do the work. I want to know if you're trained. I want to know if you have good bedside manner. So we really have to abandon respectability politics as a whole. And when it comes to non-binary folks, we do have to make space. And I want to echo what I believe it was Jammine who was before me just said. When you don't make space for me on the application, it kills a piece of my spirit.
All right, thank you so much. I just adore you, Joseph. I just adore you. Thank you so much. All right, so I want to make sure we have time for this next question because we are dwindling out of time, and I'm going to give this one to Rhonda. The question is, so how can organizations support creating more space for trans people in leadership? How can organizations support creating more space for trans people in leadership?
Well, first of all, I'm going to talk about how I got my job. Number one, I got my job because of the way I look. And I'm not going to hold no cards. They want someone who can be the token, someone who can be the face, someone they could say, this is what we created or whatever the case may be. But you have to go for the passion. And everybody may not have a degree. Everybody may not have been in college for 10 years. And it may have been hard enough for her just to get through, or them to get through high school. But their passion for what the work that they do. My passion comes from, because I've seen one of my best friends pass away from the complications of HIV, and they didn't want to talk to somebody because they didn't feel as though they had no one to talk to. So for moving forward, I vowed that there will be no one else that I knew that in my community that have to go through anything like that and don't have someone that they could talk to and discuss or even help them get help for what they need. And if they create these spaces or create these positions for a person of trans experience who has the passion, who has the heart, who has the ideas, who wants to put into their community or help the community or even educate the community, whether it be a young little girl who is cisgender or a young little boy who is gay or someone who is non-binary, whatever the case may be, just doesn't look at the person because their credentials or what they have. go deeper into the person. Why do you want to do this work? What does it mean to you? And if you ask those type of questions, you will see that more people are passionate about this type of work because they don't want nobody to fall by the wayside because they don't have no one to talk to, or they have no one that look like them that they could feel as though that I could have some type of common ground with them. So that's what people need. That's what these organizations need to look at. Yes, I did get hired because I look like this, but there are some people who don't look like me, who have the same heart, the same passion that I have within me, and they don't give them a chance. So I just say, go deeper than what their credentials have, what they have when they ask them those questions. Why do you want to do this work? What does it mean to you? How could you help? Tell me, if we put you in this situation, how could you help this situation out? Ask more questions and get to know the person better.
Oh, thank you. Rhonda, you were doing exactly what you said you was going to do, represent. Monte, you want to add a little bit?
Just very quickly to what Rhonda just said and to what Joseph said and to what Jammine said. I think putting it plain and simple, create the space, cultivate the space, and do what it is that you really say you want to do, because your actions cannot be cosmetic. And what I mean by that is it can't be on the surface just to say we checked the box. If you don't go underneath and do all the work that needs to be done, like Rhonda just said, you get that person in the door, and then if you want them to have more opportunities, create like some kind of internship or something else that's paying. Okay, you know what I'm saying? So that they can learn the ropes of the professional world, or this, that, and the third. So you don't try to change them. You take what it is that they bring to the table, you bring what you got, and then you create something powerful and magic. I'm done.
All right, so we are about to run out of time, but I want to make sure that I tap Malachi in on this question real quick. Can I tap you in, friend? Can I tap you in?
Sure. First of all, echo everything to what everyone said. Rhonda almost made me run, do the Jericho run in this office. Do not do that again when we on a panel. Start preaching like that. I would say, in my experience, just to add to what was already said, because I don't want to echo it again, but I think as people, as you get opportunity to create space for people, to pour into people what was not poured into you. Like if you know, I know when I'm hiring people what they're going to face. So as much as I can, I not only need to create space for you to grow, but really pour into you the things that I didn't know, the things that I was not taught, you know, because a lot of us who've been working here, a lot of us, you know, as Jammine said, the elders, as people who've been doing this, you know, 15, 20 years, like, you know how to navigate terrain and get through things a bit differently. You know how to get around, you know, certain things and how to face stigma. And so even just seeing these young people, I remember, and I just give a quick anecdote, as my intern returned, and I remember the look on his face as he, you know, faced like discrimination and stigma, and him just getting like so despondent. Let's take a 15-minute walk. Let me tell you how the plan. This is how you rework this. This is how you do that, because you don't want to see people, because often a lot of times when people who look like us come into these spaces and they face the stigma, they face all of the hardships, they become so despondent, they give up, they fall back. And that was a lot of what held us back and caused us to take so long to really thrive. So really just pouring into people what was needed when you were in that position.
All right, thank you so much, Malachi. Let that be our last response of the because we are running out of time. I would really love to thank each and every one of the panelists for all their insight and passion and experience that they've shared with us. It has been enlightening and so enjoyable. I mean, I could go on for another hour and a half. Y'all want to? No. All right, so we have another session coming up. Let's give a round of applause for our panelists. And at this time, I'm going to pass it over to Dana Wachter.
Thank you, Anthony. And wow, I'm sandwiched between that fabulous panel and lunch. So bear with me. My name is Dana Wachter. I'm one of the division chiefs for the Center for HIV Prevention and Health Services. So I am actually going to be talking about early intervention services, or EIS. But that's our mission and vision statement. I'm sure you guys have seen this a number of times. I have a lot of slides, so I'm not going to go over everything on these slides. But you guys will get you'll get these slides. So I really encourage you to go back and look at everything. I'm going to talk first about COMAR regulations and HIV testing. It's not as sexy as what you heard from the panel, but it's necessary. And if this is necessary because if our organizations, our agencies, our partners want to go out and do testing, You want to be able to offer quality testing, and you don't want to get shut down by the Maryland Office of Healthcare Quality. So everything I have to say, while it may not be exciting, it's necessary. So again, I'm not going to go over everything, but you guys will get these slides, and you can always reach out to me for more information. So just a reminder, there are certain rules and regulations to be followed in Maryland to make sure that everybody's safe and that testing, we have good quality testing. So that's what I'm going to be talking about for this first part here. Why are we talking about HIV testing regulations? You might get a visit from the Maryland Office of Healthcare Quality this year. They are going to be starting to do site visits again. And I don't know how much notice you're going to get for the site visits. They may just call you the day before and be like, we're coming over to do a site visit. So you want to make sure you have all your forms, all your documentation, everything is in order in case you do get that call. So are you ready for a site visit? Really quick, talking about COMAR. Maryland has very strict regulations. We are not like DC, which we joke about, it's the regulation-free zone. We do actually have regulations as far as HIV testing. So we want to make sure you're in compliance with those regulations. The bottom of this slide has is the COMAR webpage, the COMAR home webpage. You can always go to that webpage if you're looking for a regulation, and just type in the keyword and it'll pop up. I will say COMAR is like a wild goose chase or a scavenger hunt. You look up something and it's going to tell you to go to another section. It's going to go tell you to find more information. And so you could be all day looking for information in COMAR. I actually have all the COMAR HIV testing regulations for public health testing programs in Maryland, all in one spot. You guys are going to get a copy of this when you get the PowerPoint. Got to make sure you have to have a CLIA waiver if you're going to do HIV or hepatitis C testing. And when we talk about COMAR testing regs, they lump HIV and hepatitis C testing together. So this is important if you're offering hepatitis C testing also. You have to make sure that you have a CLIA that's not expired. So you want to make sure, because this is one of the things they're going to be looking for, make sure that you have an up-to-date CLIA waiver. You should be getting, if your CLIA is getting close to the expiration date, you should be getting a bill, but I don't know who that bill would go to. I mean, maybe somebody got the bill before, but that person left. So you just want to keep an eye to make sure you have you also have to have a testing permit for hepatitis C and HIV testing. And then the testing permit, the actual tests themselves will be listed on that. So it'll be HIV, the HIV test, the hepatitis C test, that will be listed on the permit. And if you have a permit, but you don't have any of those tests on there, you need to add a test, contact me and I'll give you the link on how to add that. So I'm just going to briefly run through the testing documentation because I have a lot of slides to get through and not a lot of time. But we talk about the COMAR regs. We actually, we have documents at MDH that were created to meet compliance for all the COMAR regs. I can give you, I don't have these documents on PowerPoint. I can always give them to you. You can always recreate your own, but they have to have the minimum components. So we actually have created the HIV testing daily patient log, and any of these are paper or electronic. Quality control sheet where when you run your HIV testing controls, they get logged on. You have to be keeping the temperature for the refrigerator where the controls are kept, the temperature where the kits themselves are being stored, and then the room that you're doing testing. It's all has to be logged in. Also in COMAR, you have to have competency testing, making sure that everybody knows what they're doing, making sure everybody has been trained properly. So as far as the training involved in HIV testing, that anybody who's doing HIV testing, public health testing in Maryland, has to be trained on performing the test, testing integration, clinic flow. How do you how are you going to do HIV testing within your particular clinic, whether it's outreach, whatever setting. You have to have a quality assessment plan, and you also have to be trained on blood pathogen and biohazard safety, making sure that you're putting sharps in the sharps container, using the biohazard bag when needed, using gloves when needed, etc. So anybody who has that public health testing, any agency who has that public health testing license should ensure that the following activities are being followed. Reading the manufacturer or the manufacturer's instructions have to be followed. Individuals have to demonstrate that they can do HIV testing, and it kind of goes on. Anybody who is testing under funds provided by NDH, whether you're getting direct funds or whether you're getting funds from an agency who we fund as a subgrantee, you have to go through our testing and linkage to care training, and you have to go through that competency observation at the end of the training. Okay, and this talks about the competency observation. We offer that with TLC. You have to have at your agency, if your agency is doing testing, a policies and procedures manual. Everything here is listed that should be in that policies and procedures manual. That's really important. Again, you'll get a copy of this. The public health or the person holding the public health license, the agency, has to make sure that everything's being carried out in that policies and procedures manual. That's very important. And making sure that staff they know where that policies procedures manual is and that they're following everything in there. All right, confirmatory testing, because the rapid HIV test and hepatitis C tests are still considered screening tests in Maryland. The agency who is providing this testing, if you do have a rapid reactive, the agency has to either offer to perform the confirmatory test, collect the specimen, and then send that specimen to a laboratory who does perform the actual confirmatory testing, or an active referral to make sure that that person goes to a healthcare provider where that confirmatory test can be performed. And also, if you're an agency and you don't do blood draws and you're referring that person to an agency that does, make sure there's a way to follow up. Because you want to be able to follow up with that person to make sure that they did get into care. All right, so now we're going to kind of switch gears and we're going to talk about the EIS service standards that were developed. And this kind of goes over in more detail, more about what's involved with EIS. Because I think at the beginning when EIS was first talked about, there seemed to be a lot of different things being talked about, and there were services being carried out under EIS which weren't particular to EIS. So you have your core components of EIS services. So you have your targeted testing. You notice that picture there, it is not in a clinic, it is out on the street. Targeted testing or focus testing, we really want you to go out and we want you to reach and engage the most vulnerable populations in your jurisdiction. And that means going outside the four walls in a lot of cases. Referrals, making sure that you have referrals, whether it's you get a rapid reactive or it's a negative test. Access and linkage, making sure that that client, they do get to the services that they need. Making sure that you're doing follow-up and making sure you have a protocol in place so that you do know how to refer folks and you can follow up to make sure that they got to their appointments or the other programs you referred them to. And outreach, this is not in-reach, this is outreach. You actually have to get out and you have to collaborate, make connections in the community and know where you're going in the community and engage the community. That's really, really important. All right, so EIS, the EIS approach, it's a status neutral approach or perspective. So you're focusing on the individuals from the most vulnerable populations, providing HIV testing so they know their status. If they have a negative test, then you want to make sure that you're offering, whether it's PrEP or other risk reduction services. If they have a rapid reactive test result, they should be actively, not passively, linked to treatment and support services. And you'll do an assessment to find out what those support services are. But again, it's making sure that you do your job to be able to make sure that person gets to that appointment and follow up to make sure they actually attended that appointment. EIS, it's an intensive approach. It takes a lot of work. There's a lot of research involved. You have to find out who is the vulnerable populations in your jurisdiction. You have to look at the data, all different kinds of data. Which zip codes have the higher community viral load? What areas do you need to be going into? Where and how do you engage the vulnerable populations? Where should you be going? And then you want to think about the logistics. If you're going to be doing outreach, making sure, where can you do outreach? What corner can you go to that somebody, isn't going to call the cops on you? And that actually has happened with the needle exchange program down Baltimore City. They actually had the cops called on them when they were on one of those hot corners. So you just want to make sure that everybody's on board if you're going to be going out, knowing, they know what you're doing, and that you can be there. And I know in some jurisdictions that's easier said than done, but that's where your research comes in and making connections with the community. EIS testing activities should not supplant existing HIV testing, but can significantly enhance current testing activities. So you don't want to do EIS testing or activities cannot be done in a clinic that is, a 9-to-5 clinic. If you want to, offer testing outside those office hours, whether in the evenings, on the weekends, that can be considered EIS, but you can't do it during business hours at a clinic. And we really, really want to stress to our agencies, meet the vulnerable populations where they are. I got the chance to volunteer to do testing with Baltimore City and Johns Hopkins. And I've been I was on Pennsylvania Avenue one time, and I was at Monroe and Ramsey not too long ago. And we were in a pop-up. We set up tents. We brought everything there. We made sure that we were in compliance with COMAR, but we set up these pop-up clinics. And I looked up at one point because I was doing the testing, and I looked up at one point, and there was a line going around the building for folks to be tested for HIV. And I have not seen those kind of lines since the 90s. But we were meeting the people where they were, and folks, they want to get tested. So, it was great to see folks, us being able to get out and test folks, and folks actually wanting to get tested. Collaboration is so key. You can't do all this on your own. Collaborate with other agencies serving vulnerable populations. Think about what are the agencies serving those populations, and then make a phone call. Reach out to those. Go in and visit. I know with COVID, a lot of us have gotten comfortable kind of staying, in our own houses and trying to do the work. But that's, you can do that to a point. You want to talk about social media and things like that, but you know what? You still have to get it out there. Go out and talk to people. Make a phone call. Pick up the phone. Make those collaborations. Introduce yourself to agency. Go in an agency and introduce yourself. You'll be surprised how far that will take you. All right. To be eligible for EIS services, you have to be a Maryland resident. And I know that, folks do cross jurisdictions, but that is one of the requirements. EIS is for individuals who are HIV negative, unaware of their status, or undiagnosed, individuals who have never been tested for HIV, or individuals who have been tested, but they never received their test results, or they're out of care. And you'll be amazed. You will be amazed at the number of folks, if you're out there, doing outreach, testing, they'll kind of pull you to the side, and they'll, disclose that, they've been out of care and they would like to get into care again. So, we definitely want to make sure that folks are getting linked back into care. So make sure when you go and do outreach, make sure you have all those resources with you. Don't go out to outreach empty-handed. You definitely want to make sure you have a binder, or, when I did it, it was binders, but now everything's digital. But make sure you have those resources at hand so you can actually refer people and get folks connected to the resources that they really need. All right, so documentation is everything. It's wonderful that we're providing these services, but we also have to document everything too. And this is really important because we did a site visit last year, and when we were looking at the client records, there was some of the stuff was missing, and the agency actually got dinged. So, as much as I'm a community person and I love to be out in the community talking to people, it's also really important that we make sure that we're getting all the information we need and documenting it, because that's kind of tied to the funding. So very, very important. So mandatory information, and again, all EIS information is collected into CareWare. So you have to get the date of service, the client's full name, date of birth, the residence information, race, ethnicity, sex and birth and gender identity, sex at birth and gender identity, pregnancy status, HIV risk factors, HIV testing status, and information about testing history, and HIV engagement history and engagement in care. Information that can be collected in CareWare, but it's not mandatory. The location, the name of the EIS worker, the client street address. Not all of our clients are going to have a street address. Phone numbers for clients. We can, in CareWare, we can do custom fields, and we certainly can work with your agency to do that. So if you need to collect the last 4 digits of the client's Social Security number, primary language, use of text messaging for client follow-up, we can certainly help you out with that. All right, key service components and activities. EIS, it's targeted outreach. So you really have to think about the populations, and you have to do your research regarding the populations you should be focusing on, and where those populations are, how to engage those populations. HIV testing expansion. So it can actually be an expansion of your current testing program. And we talked about that before with expanding clinic hours. Joseph brought up a really good point in the panel too, when he was talking about there's no more walk-in clinics anymore. So you can make if your HIV testing clinic is not currently, if it's appointment only, offer walk-in. I mean, that's really, really important to people. If they realize that, they can have a moment where they realize they need to get tested for HIV or want to get tested for HIV, and be there for them. That's really important. Assessment of unmet needs. We'll go over that in a second, but you do have to do an assessment, and that's actually very helpful for you to be able to provide resources for those folks. Linkages and referral services. Again, very, very important. We want to make sure that we're getting people linked to care and other referral services. Provision of health education and risk reduction. We'll talk about that in a minute. And then there's the EIS case closure. Targeted outreach. We keep talking about targeted outreach, focused outreach. Again, it's addressing those vulnerable populations, identifying individuals unaware of their status, meeting the populations where they are. You want to target your activities into specific areas. Again, collaborate with agencies. I worked for Baltimore County Health Department. It was a long time ago, but I worked there. And but this is what we did. We would go out. It's very rarely that I would test in the clinic. I was always out. And it could have been, if there was a particular neighborhood that I wanted to offer testing in, I would canvass that neighborhood on foot, and I would go and introduce myself and meet people. And there were so many agencies that weren't advertised, but I was able to make a connection with. They were serving those populations, and they were happy to bring me in, and I would do HIV education, and then out of that HIV education session, I would get so many folks tested. And then people actually brought me in on a regular basis. There were many, many different shelters and homeless service providers and treatment centers and welfare to work agencies. There's just mean, I did senior centers, and that was really funny too. I got some funny stories from that one, but think outside the box. Don't limit yourself to an HIV service organization or, an STI program. Think outside the box. And again, these are non-clinical settings. Engage individuals to provide information and education on accessing healthcare and other services. That you may be something, this person may have gone through some trauma, and you may be the only person either they felt comfortable talking to, or you're the first person there, to help them. So, engaging individuals is so important, and gaining their trust too. And then initiate the linkage to care for individuals who know their HIV positive status and have never been in care or have not attended a medical appointment in over 6 months. So for the HIV testing encounter, you have to collect the mandatory client information and demographics that we went over, complete an assessment of HIV testing history, and offer HIV testing and document HIV testing activities. And if a referral for HIV testing is provided, this has to also be, everything has to be documented. If you're doing something, it needs to be documented, but also document that follow-up information. That is super important. So this is also important. This is the stuff we look for on a site visit when we look at the client records. And if these things are not being documented, the agency will get dinged. So this is super important. Assessment of unmet needs. For every EIS encounter, these things must be assessed regardless of HIV status, housing status, health insurance status, and mental health and substance use. That is absolutely mandatory. And again, if those things are not documented, as far as an assessment, your agency will get dinged. Health literacy and STI screening are optional. And everything gets documented in CareWare. Linkage to referral services. You can actually initiate the linkage to care process upon a rapid reactive test, and you should be doing that. That really helps, with making sure the client can get access to medical care in a timely manner. But it also, and also start the partner service information. You can collect information on that also. Follow-up is important. Client with a negative test, you can link them to prevention services, including PrEP. And I am running out of time, so I am going to have to speed it up here a little bit. We talked about health education and risk reduction. This used to also be under CDC funding, and I think people with CDC funding, we had curriculums we had to follow. This is a little bit different. So what exactly is HERR when we talk about EIS? So all these things here are included in HERR with EIS. So there's a lot there. You also have to document the HERR activities. So, it's going to be the date, the topics, the number of participants, if it's a group intervention, the duration, client feedback and client outcomes are really, really important. And that kind of helps everybody. So to read up on all the key service components of the EIS service standards, as well as the measures for each component, we actually have service standards that were written. So all that is in there. And we want to make sure that we all are familiar with that if you are performing EIS services. And I know that was a lot to take in. We only have 3 minutes left. So if anybody has any questions. What if the first test was a blood test? So that wouldn't, if it was a blood test and it was sent to the lab, then that wouldn't, you wouldn't have to do a confirmatory because that's a blood lab test. So you could just go ahead, go ahead with that. I'm not even too sure how long it takes to get the results back from a blood test. I guess it would depend on the lab you sent it to. Hopefully it won't take the 2 weeks that we had to wait when I first started doing HIV testing. But you would have to wait to get the results back. If the first test was a blood test, you would have to wait to get the results back and then start the linkage to care process. During outreach, people are willing to be tested, sometimes not willing to give details, give detailed personal information. You can't force people, you can't strong arm them. I mean, you can only, but you know what? Document the fact that they wouldn't give you that information, because we do look at the notes. So notes are very, very important. You don't want to push people too hard. And I think it's the way you serve it up too. But you don't want to push people too hard, because if you push them too hard, they may not come back. You do want to gain their trust. Did the CDC change the requirement? What requirement is it? I'm not too sure what requirement you're talking about. You didn't specify. Okay. Yeah. There's my email there, and my work cell phone. You guys can feel free to reach out to me for anything, any HIV testing questions, any COMAR questions. If you need copies of the documentation forms that we use, again, the documentation forms that we've created at MDH, they actually they have everything in there that the Office of Healthcare Quality requires. And I really encourage you guys to look at the PowerPoint slides when you receive them, and just make sure that you have everything ready in case you do, you should have it anyway, but in case you do get that visit from the Office of Healthcare Quality, reach out to me if you have any questions or need anything. I'm certainly happy to help. This is kind of my passion, so I love doing this stuff. All right, I think we are about up. So thank you all so much for your time and attention. We're now ready for lunch, yay. So we'll see you back here at 12:30 for our final afternoon session. See you soon.